Most patients that develop coronary artery disease will develop one of two symptoms. The classic symptom is chest pain on exertion. So they will have discovered that over the space, it takes a few weeks or so, sometimes even longer, for the patient to be aware of what's going on, that they will discover the fact that things that they could do previously, they're now struggling to do. And classically, they will get a pain that is not a sharp pain, it's usually a sort of a dull pain. It can affect them anywhere from their jaw down to where their ribs meet, and it will be reproducible. That's to say that every time they do a certain amount of exercise, the pain will come on. Some patients don't get chest pain on exertion, but they become breathless. So in a similar way, tasks that they could previously have done, say for example walking up a couple of flights of stairs, they find that after one flight of stairs, they're struggling, they've got to stop for breath. And we call that angina equivalence. That's to say that the problem is caused by a blood supply problem to the heart, but it manifests itself with breathlessness rather than with chest discomfort. Some patients just notice a general change in their overall demeanour. They often just become tired and listless, and it's not just the kind of tiredness that most of us complain of. These are people that really are so fatigued that their quality of life is significantly impaired, and so that's something which then brings them to medical attention. And so having identified those potential or those symptoms that may potentially be related to a blood supply problem to the heart, the patient would then have a diagnostic angiogram. That's where we insert a catheter to then inject some fluid down the coronary arteries and see what's going on. And if there is a narrowing which is of more than 60 or 70% diameter of the artery, then we know that that is what we call a flow limiting lesion, and that is therefore very likely to be responsible for restricting blood flow to the heart muscle, and it's that's responsible for the patient's symptoms. Sometimes, if it's so obvious and if the symptoms are so good, and especially if the patient is deriving benefit from anti-anginal medication, then clinically it's perfectly justifiable, I would argue, to then proceed directly to angioplasty and then to dilate up the narrowings and get rid of them and hopefully relieve the symptoms. Sometimes, if it's a bit equivocal, then there are other investigations that can be done to demonstrate that the heart muscle, which is supplied by that artery, functions less well when the heart's under strain compared to when the heart is resting. And we call that demonstration of ischemia. And so what we're looking for there is absolute evidence that that narrowing is having an effect upon how the heart works. And in that situation, then we have clinical information, i.e. the patient's symptoms. We have the results of non-invasive investigations, and then that leads to, when you ally that to the angiogram, then there's clinical justification to proceed and perform angioplasty. And the reason for that is that we know that, in theory, the clinical benefits of performing the procedure will significantly outweigh the clinical risks.